Good afternoon, everyone, and thank you for joining us. I'm Sean Godar, Vice President of Strategy and Analytics at Employers Health and co-director of Right Direction. I will serve as a moderator of this event. Currently, we're experiencing a little bit of technical difficulties with our speaker, so she will not be on her camera will not be on. So please be a little patient with us while we deal with that. We will continue with the webinar as scheduled. A few housekeeping items before we begin. All attendees are currently in listen-only mode. Submit your questions anytime in the Q&A section, and we will answer those during the Q&A session. We also encourage you to share with us some of the things that you're doing with your mental health initiative. If you ever have any difficulties hearing me, send us a message in the Q&A as well. Finally, there should be a handout section in your control panel where you can download materials related to today's presentation. Upon exiting the webinar, you will receive a survey to provide feedback. We appreciate all attendee feedback in order to provide future valuable education opportunities for upcoming events. We will also send out a follow-up email tomorrow with a link to the recording of the event and its accompanying handouts. Today's presentation is Suicide Prevention is All of Our Business, and it is brought to you by Right Direction. Right Direction is a partnership between Employers Health and the American Psychiatric Association Foundation for Workplace Mental Health. It's a free turnkey initiative focusing on increasing awareness, reducing stigma, and facilitating help-seeking behavior for mental health in the workplace. And it can be used in conjunction with other mental health services and programs. And with that, I'm going to turn it over to Darcy Grudadaro, Director of the American Psychiatric Association Foundation's Center for Workplace Mental Health and co-director of Right Direction. Darcy, go ahead and take it over.
Thank you so much, Sean. And thank you so much, all of you, for joining us. We're so pleased that you're here. We did want to say it's 2021, so of course we're having a technical glitch, but that's okay. We can address that, no problem. So we're really delighted to have our keynote speaker, and I'm going to introduce her in just a moment. But first, I did want to share that Right Direction is a high-impact turnkey initiative. It's really designed to raise depression awareness, reduce stigma, and promote help-seeking behaviors. We have a few of our more recent resources included on the slide so that you can get a sense of what we have in our latest and greatest when it comes to depression awareness and when it comes to encouraging help-seeking behavior. So I did want to now introduce, because we're very fortunate to have a wonderful keynote speaker in Dr. Jodi Frey. Dr. Frey is a full tenured professor at the University of Maryland School of Social Work. She chairs the Social Work in the Workplace and Employee Assistance Subspecialization and the Financial Social Work Initiative. She is also the founder and faculty executive director of the newly launched Behavioral Health and Wellbeing Lab. Dr. Frey's research focuses on workplace behavioral health, including the impact of employee mental health, substance use, and well-being on productivity and safety. She is certainly also a well-known researcher and expert on suicide prevention. And given this is Suicide Prevention Month, we are really excited to have her here with us today. We will be advancing her slides, so she'll be letting us know when she'd like us to advance them because of the minor technical glitch, but we're just delighted to have her here. So with that, I will turn it over to you, Dr. Frey, and you are on your first slide.
Thank you. Thank you so much for that warm welcome. And it's wonderful to be here during Suicide Prevention Month to speak with everybody online about some different ways that we can all be engaged to make suicide prevention part of all of our business. So I'm really honored to be here, and I'm sorry that you can't see me, but we'll do our best. Technology is always a little finicky. So go ahead and advance, and the slides I'm presenting today are go back just one. The slides today that I'm presenting are part of a presentation that we use with the Workplace Suicide Prevention Committee and their national guidelines. And so while we want you to share them widely, if you do want to, use them in your own presentation or change them, please ask permission from myself and Maggie Mortali at American Foundation on Suicide Prevention and Dr. Sally Spencer-Thomas. Next slide. So let's start off today thinking about what our business is doing, and I'll also tell you a little bit about how I got into this work. I'll start with UP, Union Pacific Railroad, one of our high-risk industries, as we're going to learn about during this hour in terms of suicide risk. they actually had senior leadership involved with their health and medical and their EAP to really say, we're going to make suicide prevention part of our everyday language and approach, and really bake this into everything we do. And they put resources behind it, not just lip service in terms of thinking about taking a stance for prevention. And in fact, just a few years ago, they did a stand down for suicide where everybody was able to take time and volunteer and really talk about well-being, access to resources, and suicide prevention centrally. So Union Pacific is highlighted in the case studies for the American Psychiatric Association Center for Workplace Mental Health, and I would encourage everyone to take a look at that. I also want to share this story over here with John Kinning from RK Construction. My colleague who helps to lead the dissemination of the guidelines met John Kinning in Colorado many years ago. And even before we had the data that I'm going to share that shows the high risk for suicide among the construction industry, John recognized that suicide was affecting his men. And he wanted to take a proactive approach to do something about it, even though we didn't have the data yet to really support that nationally. And so he worked with Dr. Sally Spencer Thomas to create a blueprint for construction suicide prevention that his foundation for RK Construction backed. And he said, I don't want to wait till there's a next crisis. Let's get this out nationally. And what we're going to see actually during this hour is construction has actually taken quite a lead in helping us to move forward and thinking about business strategies for suicide prevention. Next slide. So just a little bit about our team. I mentioned Dr. Spencer Thomas and Maggie Mortali. The guidelines that I'm going to introduce to you today are part of all of our organizations. And the way that I got involved as a clinician actually in the workplace doing employee assistance was that I continuously saw increased risk in the 90s when I was practicing and into the 2000s, and the workplace was just not doing very much about suicide prevention. We were really focused on workplace violence and homicide, but when it came to violence to ourselves, to suicide, we were very quick to kind of brush it away if there was a suicide crisis at work. And actually, I won an award in 2001, I think, for some of my work at a federal organization in their employee assistance program. But I got a compliment that was interesting. They said, Jodi, you're kind of like a broom. When bad things happen, you quickly help to sweep them away. And so at the time, I thought I didn't really have the voice yet to talk about that, but it wasn't the most beneficial compliment I wanted to hear, because what we really needed to do was not only to help continuity of operations and return to normal with the workplace, but we needed to be more proactive and preventive and learn, whether it be a suicide crisis or other crisis, of what we could do differently. So that helped drive some of the work that you're going to hear about today I'm involved with. Next slide. And some of the members of our committee represent lots of different industries and disciplines. Next slide. So I'm going to try a polling question. That's doing a lot here. I actually have it here. So I'm going to start the poll and see if it works. But I'm going to ask before today, if you can answer yes or no. Were you familiar with the workplace suicide prevention guidelines? All right. We've got some responses coming in. Great. All right, so I can see that the majority of us are not familiar, and that doesn't surprise me because they actually are relatively new, and that lets me know that we've got some great information to cover. Next slide. So what I'd like to do today is to introduce you to the national guidelines and help you understand how you as a member of a workplace or a professional organization can start to become more suicide informed. And then I'm going to give you a homework because I am a professor. So I'm going to ask you to become an official pledge partner and tell you what that means. Next slide. So when we look at the data, this is actually from 2019, and this is our most recent comprehensive data. There's some lagging indicators. It takes some time for our data to come out, but almost 50,000 people a year die by suicide. And in fact, up until this year, suicide's been the 10th leading cause of death. And just in 2020, COVID is now the 3rd leading cause of death, so suicide is the 11th. We actually saw in 2020, some of our initial data is showing about a 5.5% drop in suicide deaths. However, people often ask, like, what is the effect of COVID on suicide? We're not going to know for many years. And I just was interviewed the other day on a news article, and I said, I don't need to wait for the data to do something. I know the risk is increasing. And when we look at the data for suicide that's coming out more recently than this slide, we're actually starting to see really different subgroups of populations disproportionately affected by suicide risk, including Black Americans, Indigenous persons, and other people of color, as well as older adults and younger adults. So I think it's going to be really interesting to look at the data over time, but what I'm going to encourage everybody on this call is don't wait for the data to get involved. Next slide, please. I could teach an entire class on this. In fact, I do for social workers and nurses, but I think it's just important to take a glimpse. And if you're interested in the theory behind suicide risk, I highly encourage everyone to look at the work by Dr. Thomas Joyner, who developed this model for suicide risk. And it really helps us to understand what's happening in terms of when ideation becomes behavior. And Dr. Joyner talks about perceived burdensomeness and thwarted belongingness, and those two together kind of make up this desire for suicide. But that doesn't necessarily lead to suicide attempt or behavior without capability. And we can think of capability in a very general sense of having the means. So this gets us into the workplace. You know, do we have access to lethal means? Do I have access to knowledge about lethal means? Or perhaps have I been exposed to many traumas over my lifetime, both at work and at home, that increase my capability or reduce my fear for acting on my suicidal ideation? So it's a really interesting model to think about as we kind of heat map that over different industry risks that I'll show you. Next slide, please. So this is actually a quote from 2001 from the Wall Street Journal, and it's still really relevant today as we think about the workplace as the last crucible of sustained human contact for many of the almost 50,000 people who kill themselves each year in the US. A coworker's suicide has a deep, disturbing impact on workmates, and for managers, such tragedies pose challenges that no one covered in management school. Managers are often in a position where they're not only able to observe and see changes that could be related to suicide risk, but they usually really care about the people that work for them. And they often want to do something to help, but they don't know what to do. And then we become paralyzed in fear when we worry if we're going to say the wrong thing, you know, or if we're in a litigious type of environment. And so they end up saying the wrong thing or doing nothing. But in actuality, coworkers and managers are very concerned and usually very interested in learning, what can I do? Next slide. So in 2020, a little bit before there was a prior report in 2016, the CDC finally came out with data that really helped us understand industry and occupation risk for suicide. This is very critical as we think about not all businesses are the same. And when we have limited resources to invest, we need to make decisions about perhaps where do we put more of our resources. As I already mentioned with RK construction has continued to be at some of the highest risk for both occupation and industry for men and women. And when you look at this list of the top 5 occupational groups, this is for, by the way, data from 32 different states that participate in the National Violent and Death Reporting System that the CDC uses to estimate occupation, and then the next slide will show industry rates. But these 5 occupational groups were statistically more significantly at risk for suicide death than the general population: construction, installation, arts and design, transportation, protective service, and the 6th one is healthcare, by the way, for females. A lot of the male-dominated industries rise up to higher risk. When we think about Dr. Joyner's model that I just referenced, there's means, knowledge, and access. Some of these areas in terms of occupations have more social isolation. They're physically demanding, and we know that pain is related also to suicide risk. And a lot of the male-dominated industries really encourage self-reliance. Should be helpful at the job, but we know actually as that gets reinforced, increases suicide risk by reducing help seeking. Next slide. This is a slide that Dr. Spencer Thomas put together to highlight the top 10 industries at risk for men. And a lot of the work that I do focuses on working-aged men because we know that 80% of suicides in this country are men. And so we can see here mining, oil and gas, construction, other services such as auto repair, agriculture and hunting and fishing, transportation. When we look at some of the risk factors in a moment, we're going to see how industries and occupations can really think about their risk picture overall, and that there are aspects that we might be able to start reducing risk from the workplace. Next slide. I do want to mention that suicide death is a crisis at work, but not the only suicide crisis. When we think about the impact of suicide at work, we're also thinking about attempts, we're thinking about caregivers that have a loved one at home struggling with suicide intensity, and grief. So yes, suicide death, as I showed you in those last two slides, is important, but it's not the only indicator that should drive us to take action. So in the workplace suicide prevention guidelines, we really frame suicide prevention as a health and safety priority. Some of that has to do with the industries and occupations that you saw that really revolve around health and safety and have, jumped in full force to address suicide prevention. But we also are able to understand that when someone is struggling with suicide ideation, there's distraction, there's impaired perception, fatigue, and we know that mental health and physical health are intertwined. But when work is functioning well, it can also be a wonderful place, or that last crucible, as the quote talked about, to foster social support, to increase connectedness, to give a sense of purpose, and to provide a sense of solidarity. So what we're going to look at the guidelines today talk a lot about culture. Next slide. So the suicide prevention guidelines, the national guidelines, they're not just like Jodi or Sally or Maggie's guidelines. We actually used research through focus groups and interviews and surveys to understand what it is that employers and professional organizations want and need as they think about having guidelines. So we used a data-driven approach to create the guidelines. Next slide. And this is actually our website, suicide prevention, workplacesuicideprevention.com. Where anyone can go. There's lots of resources, and this is where I'm going to send you for that homework later in terms of signing up for the pledge. Next slide. The partners involved in creating the workplace guidelines include the American Association of Suicidology, for which I'm the co-chair of their committee, the American Foundation for Suicide Prevention, and the United Survivors International. And I'll tell you that this project is not unique just to the US. We've actually been working as a task force and committee in different formulations since 2010, when we started off with the National Action Alliance for Suicide Prevention and created the first workplace task force. And we then looked at other countries like Canada in 2013 that launched standards for psychological health and safety in the workplace, followed by Australia in 2014 that published work and suicide position statements. And then finally, that data that I showed you came out from the CDC in 2016 and then again in 2020 to really put on the map how workplaces are affecting and have a potential opportunity to reduce suicide risk. So these guidelines were just launched in 2019 on World Mental Health Day. And since that time, we've had over 750 workplaces and professional organizations take a pledge to make suicide prevention a health and safety priority. Next slide, please. So, and actually we can skip this slide. This was just what I mentioned about the numbers. So the workplace suicide prevention is based on 8 guiding principles and 9 practices. And when you go onto the site and take the pledge, you get access to a learning community that provides videos and information and best practices of how you can implement these at your workplace. I'm not going to go into too much detail, but I just want to mention each one because these 8 guiding principles overlay all of the practices that I'm going to give you some examples of today. Strategic integration. Again, we see workplaces as being very uniquely positioned to be part of the larger public health approach. So the title of this presentation, that it's everybody's business. We think workplaces can be very involved in prevention and response as we think about a health and safety priority of suicide prevention. We also think it's important to have a comprehensive and sustained investment, and that includes having upstream, midstream, and downstream approaches. So think about a coffee drip, a small drip over time in all the different layers of your work organization as compared to a one-time training and, check the box, we've done that. The third principle is harm reduction, and we think putting safety and health first can help to decrease harmful exposures, and that can include psychosocial hazards that can increase the risk for suicide. Culture cultivation offers protection from suicide. So this gets back to when work is working well, fostering connectedness, a caring community, a place where we look out for each other, and leaders actually are recognized and rewarded for supporting and encouraging these types of values. Dignity protection, we can prevent despair and promote healing. What type of workplace are you in? Bullying, harassment, discrimination, prejudice, toxic workplaces really increase suicide risk, our research is showing us. Can we work to have more dignity and a respectful reintegration of our employees? Our well-being principle talks about, again, it's not good enough to keep pulling people from the brink. We want to really enhance hope, resilience, and give people a purpose for living. Empowered connection is connecting to effective treatment. And this might include peer support. As we saw in the UP example, they've got a wonderful system of peers that are looking out for each other compassionately and helping to link other employees with care. And finally, being action-oriented. Workplaces need to engage in action through policy training and other tactics that we have documented through our strategies. Next slide. So I don't know if you've heard of the stream parable, but it's something we use in workplace suicide prevention to really get us thinking about upstream approaches to suicide prevention, and it can be used in different ways. But oftentimes we focus at the bottom of this picture, the mental health and the crisis response, again, pulling people from the brink. So imagine you're at the side of a lovely stream in this picture, and all of a sudden you hear, help, help, only to look over and see someone's drowning. Your fight or flight response checks in and you jump in the water to save someone. You pull them out with all your might onto the side of the river, and they live. And you're feeling so fulfilled. You're so happy that you're able to save this person, only to hear a moment later, help, help, someone else is drowning in the river. So you jump back in, but you're tired. You pull the person out, and then you look over to see all numbers of people drowning in the river. You can't do this work alone. So you see a bunch of people sunbathing and you say, help, I need some help. Come on over, help me out. And of course, the community comes running. And we get into that midstream approach where, we're working together. We've got some peer support. And hey, maybe you know CPR, but now's not the best time to be training folks when you're in the middle of a crisis. So you step away. People are getting burned out. There's more and more people falling into the river and drowning. And you start to walk up the top of the mountain, only to hear, where are you going? We need you here on deck. Come back. And you say, I got to go to the top of the mountain because I need to see why people are falling in the river to begin with. And that is what brings us to this upstream approach. Yes, we need to be there for crisis intervention. And when people are having potentially the worst day of their life, we have to bring it all as clinicians and counselors. But as leaders of workplaces, we need to be more proactive and think about, is there functionality in our work environment that's increasing risk that we can reduce? And then are there ways that we can prepare in a midstream approach, all hands on deck, so people know that CPR before someone is drowning in front of them? Next slide, please. So the 9 practices in the workplace guidelines are designed. The top 3 are upstream: leadership, job strain reduction, and communication. The middle row, self-care orientation, training, and peer support, or well-being ambassadors, are our midstream approaches. And then our bottom downstream is mental health and crisis response, mitigating risk through things like lethal means reduction and crisis response. So let's take a look at some of these. Next slide, please. So in our upstream, we'll talk a little bit, I'll give some examples of culture, job strain and toxic work contributors, and communication. Next slide. So this is a really busy slide. It's one that I hope you'll download and take a look at later. We are getting some really interesting research, some of it out of Australia, led by Dr. Alison Milner's lab, to really understand how work is directly related to suicide risk. And what we're finding are that there are some key outcomes when we look at large databases, including job insecurity, lack of job variety, work-family conflict, increased job dissatisfaction or feeling trapped is a big one, work that's not meaningful or rewarding, and then more research is coming out more recently on racism and discrimination in the workplace as it relates to suicide risk. So these are factors that we could really dive into from an organizational assessment perspective and try to change some of them from the top using an upstream approach. Next slide. This might look familiar to some of you who are in work and safety and health industries, particularly from NIOSH, the National Institute of Occupational Safety and Health. This is their hierarchy of controls. And again, it's just a different way of envisioning and kind of getting buy-in from leadership to think about where do we put our resources. The majority of our resources that we use are in that downstream approach at the bottom of the pyramid here, where we encourage personal resilience and recovery. But as we work our way up the pyramid, we actually start thinking about how to reduce some of those threats on the previous slide to improve psychological safety. And what we find from the NIOSH model is that those that really start changing the culture have the greatest effect. Next slide, please. I love thinking about the state trooper effect. It's too bad I can't see all of you because I could tell by your eyes how your response might be. But think about you're driving down the highway, right? And you see on the side of the road, state trooper. What do? If you're like me, you probably slow down. What do you continue to do? Some of us, not necessarily me or anyone on the call, might be looking in their rearview mirror, and as soon as that trooper is out of sight, they speed up again. So the idea behind upstream approaches to workplace suicide prevention is to make sure it's integrated everywhere so that it's not just when there's a training or a leadership message or an incident that we think about suicide prevention and well-being, but we really cultivate leaders in our workforce to share their story, to share stories of hope and resilience, to really think about rewarding managers that encourage health seeking, that encourage and foster connectedness, and think about some creative ways. There's some mental health toolboxes out there. People are using pulse check surveys. Construction has built it into some of their mental health toolbox talks. So before a shift, they get together, and in addition to health and safety messages, a lot of those messages are focused on suicide prevention and psychosocial well-being. So really thinking about, ways to bring this in regular communication to get past that state trooper effect. Next slide, please. So it'd be great. I'm not going to stop because of time. I know I started a little late with the technology, but if you're able to put some examples of how you have workplace policies or programs that represent upstream practices, please go ahead and add some in the chat. We could learn from each other as we see them populate. Oops, sorry. So midstream approaches, let's dive into this for a couple minutes and thinking about training, management training. This is actually a model developed by Judge Mary McClatchy, who is actually working with us on a paper for HR and legal that should be out soon, and I'd be happy to share it with folks when it's available. But this is kind of what she calls the silent suicidal spiral at work. The employee has some performance problems, they're recognized by a manager, and we focus only on performance. We don't think about health, well-being, work life. That puts more pressure on the employee, and performance usually gets worse. And then the employee might feel harassed or isolated. The trust is eroded, and that increases suicide risk. What happens after a crisis, a suicide crisis? Disability accommodations might be limited and can increase for litigation. It's kind of an extreme example, but one that gets the attention of employers, whereas we might be able to think about in a different way if we teach empathic emotional intelligence response to managers, they see the performance problem and they recognize that it could be something going on in this employee's life, could be emotional, relationship, mental health. And so rather than only focusing on performance with a performance improvement plan or a last chance agreement, maybe we ask some questions. Are you okay? How can I better support you? And then we think about mobilizing our resources, whether it be a referral to employee assistance, to a peer or a buddy, or to other professionals that are available to support. That tells the employee that you care about me, that you're concerned, and it builds my strength and it builds my desire to really want to engage in help-seeking behavior while also increasing the performance at my job and reduces litigation. Next slide. Some other ways in terms of midstream approaches, next slide, that's just a fun one that we put in, are to think about screening. So right now, I'm hearing from so many employers that want to be more proactive, which is wonderful. After 20 years of doing this work and banging my head against the wall of why mental health is important, I'm actually very hopeful, despite some of our risk indicators, that employers are really taking mental health and well-being seriously. And one way that they're engaging in trying to reach out rather than waiting for that performance problem or waiting for someone to have to call a crisis line or an EAP is to think about getting out there with screening, whether it be for depression or well-being or the pulse checks. There's an interesting program, next slide. I'm actually evaluating it for the American Foundation of Suicide Prevention, and the results should be out in a couple months. We're finalizing that, called the Interactive Screening Program. This is a really interesting program that was designed initially for college campuses to provide access to standardized screening and anonymous dialogue with a counselor, whether it be an EAP or a peer program or a behavioral health embedded program. And people can get immediate feedback and response, and they never have to give their identity. And so I think it's just another creative way that we're thinking about how do we reach employers without necessarily waiting for them to call us. What are other ways that we can break down the barriers and the stigma to help seeking? So it's one to check out if you're interested. Next slide, please. A big piece of doing this meso level work or midstream work is training. Next slide. And what we recommend is a stratified suicide prevention training program, really into triangles and pyramids, as you can see in the guidelines. At the bottom of this triangle, it's kind of the CPR model of suicide prevention, which is a gatekeeper training, meaning that everybody can be trained to ask questions and to be able to refer someone for additional help. They don't need to be a clinician or a doctor to ask, are you okay? I'm concerned about you. Can I tell you about some resources where you could get confidential coaching or counseling that might be helpful? These are, that's the gatekeeper training. And a lot of workplaces are starting to think about mental health first aid or QPR or assist. There's lots of different options that are also listed on our website for resources. The next level is when you might have a peer program, or you might have some additional training for your managers. So they need a little bit more. It's that EMT level. And at the very top is making sure your clinicians are ready. And I mentioned that the importance of crisis response when we need to respond at that level of professional risk assessment and management, we need to make sure our providers have up to par skills. The science is changing every day with suicide prevention, and things that I learned when I was in my master's in social work program 20 plus years ago are no longer best practice. So as we think about managing our workplace behavioral health programs, we want to make sure we're asking some questions, and I list some of them in our downstream approaches. Next slide, please. This is another example of a gatekeeper training for managers, specifically Dr. Sally Spencer Thomas created it for Working Minds, and it's offered out of Colorado if you're interested to look up some other models. Next slide, please. So we're not going to show the video, but I think we can put the link in here. The video is actually John Kinning from RK, a couple years after he implemented the program in his construction agency to really see how they fostered peer support, leadership messages, and built in some of those toolbox talks. So it's just a couple minutes. If we have time at the end, we can maybe go back to it, but I'm going to go ahead to make sure we have some time for Q&A. So let's close off with some downstream approaches that are highlighted here in terms of mental health and crisis response, mitigating risk, and then responding to suicide crises. Next slide. So Sally and I wrote, an article called "Kicking the Tires to Your Mental Health Providers." And it was, really engaged to think about, like, who is providing your service? Are they trained to work with folks that have suicide thoughts and intensity, feelings, behaviors? What are they doing in terms of risk management? And where are they referring people to? That's really important, because as we open up our doors to help seeking and break down barriers, we want to make sure that our network of providers are really trained and capable and have appointments available and can see people. There's a couple resources on our website that we refer to that are evidence-based suicide clinical programs, like CAMS by Dr. David Jobs is an assessment and management of a collaborative assessment and management of suicidality. There's also suicide-focused CBT and DBT. It's no longer acceptable to do family therapy when someone in that couple or that relationship is suicidal, and we just hope that the suicide goes away. The focus needs to be on the suicide crisis, the suicide intensity, and working through safety plans and really thinking about a support network in the community. Next slide. As much as we do to prevent suicide, we do need to be prepared for a crisis response. Next slide. And so there's this manager's guide. I don't know if anyone has seen this. We created it a number of years ago through our committees, and I find it to be one of the best tools out there for managers and for HR professionals that find themselves trying to manage a suicide crisis at work, whether it be a death or an attempt or a grief incident. And one thing that I like about this guide, it's freely available online on workplacesuicideprevention.com, so feel free to download it. It gives us actual communication templates and flowcharts to follow to guide us through the different phases of suicide postvention. And I'll just introduce the 3 phases to you briefly. Next slide. So the first one is the acute phase. How do we contain the crisis? How do we set the tone to coordinate communication with people that need to know? And that involves, how do we protect the privacy of the deceased while also not making promises that we can't keep in terms of confidentiality. And the guide even includes a sample letter that we can use in terms of death notification at work. And then getting into some of the safe messaging guidelines, because language matters. We want to make sure that we're balancing respect and memorializing without dramatizing or sensationalizing a death. And how do we maintain internal and external communications? And then how do we offer real support? Meals for the grieving family, packing up belongings, helping with that direct support that people need in a crisis. Next slide. The guide then walks managers through the short-term recovery phase that thinks about, linking folks that are survivors, which include coworkers, with different resources of crisis counseling or employee assistance, community support. There's not really a one-size-fits-all, so we want to be able to consult with managers and think about ways that we can encourage help seeking over time, as well as paying attention to how folks are mourning, what they need for healthy grieving, while balancing that with that continuity of work and being an effective leader during this time to restore and establish equilibrium and optimal functioning. And finally, it talks about long-term reconstruction. And we know that anniversaries and events and milestones can be triggering for workplaces. It's complicated. And we want to make sure that we celebrate life, whether it be small or privately, and be respectful while also thinking about, how we can support others that might have long-term grieving. And then the number 10 is so important. How do we transition back to prevention? I told you early on that I got named the broom. I swept it away. That is not where we want to be in terms of working these guidelines. We want to be able to prevent suicide, but when it happens, we want to learn from what happened and what strategies we could improve at the workplace. So really bringing that full circle. Next slide. So here's your homework. We'll skip this one. So pledge today. Go to workplacesuicideprevention.com. You can be an individual, you could be a department, you could be an entire workplace. We've got all size organizations that take that initial step in that pledge. It doesn't commit you to, doing everything in the guidelines. You can start anywhere you want, anywhere that makes sense. And when you take the pledge, we actually have a free organizational assessment that you can take to think about where you might start, where are your strengths and where's maybe some of your low-hanging fruit, and where are some places that really are going to take an investment of time and resource to make a dent. Next slide. When you sign up for the system, we give you a badge, because who doesn't like to be commemorated in terms of a step that they took? You actually get the first badge as soon as you take a pledge, and as you work through some of the steps, it could be watching a video, it could be thinking about hosting a depression screening at your workplace, you get badges that you can share with others, including your employees, so that they know you're actively working to become more suicide informed. Next slide. These are some resources. All of these are hot linked on the PDF, and there's many more on our website, including multimedia, and I hope that you will take a look at that. Next slide. We're very active on social media, so please reach out to us on Twitter, Facebook, Instagram, and LinkedIn. We try to highlight workplaces that take the pledge, give you extra kudos, and provide support and different ways that you can share infographics and information with your employees and your networks. And I think that takes us to the end. So hopefully we have some time for questions, and I just want to say thank you so much for allowing me this time to introduce you to the guidelines.
Thank you so much for speaking with us today. We learned a lot. Before we go on to the question and answer session, we would like to thank the generous support from our funders, Takeda and Lundbeck, who have helped make Right Direction possible. And please, let me see if it's on the next slide. Yes. Please check out our website at rightdirectionforme.com for resources, guidance, and best practices for mental health in the workplace, as well as information on any upcoming webinars and virtual events. At this time, we will begin answering the audience's questions. And the first question I have here is, the psychosocial hazards of work overlap with elements of burnout? Would you speak to that overlap?
Yeah, Darce, that's a great question. Actually, something that is probably becoming even more critical now as we think about the 6th leading occupation among women that was not on the slide, but I mentioned was healthcare. Burnout in all different industries and occupations overlaps quite a bit with the psychological hazards. And if you think about work that is not meaningful, work that has no variety, work where you're feeling isolated, those are all similar risks. So one of the models of suicide prevention that I looked at very early on when I started this work was the U.S. Air Force model, which was a comprehensive model that had 11 initiatives. And obviously the military is able to do some things that civilian workplaces can't do. However, one of the areas that we found when it was fully funded, they were able to reduce suicide death that was sustained for 10 years. And in doing that, they actually had an impact also on substance use and on violence and other risk factors. So the reason I bring it up is because when we focus on suicide prevention, we have this additional secondary effect that positively impacts so many other aspects of quality of work, work life, and emotional health and well-being.
Thank you. As organizations raise depression awareness and encourage help-seeking behavior, how does suicide prevention overlap with depression and making it and other mental health issues more visible at work?
That's a good question. There's a lot of initiatives right now that are focused on mental health becoming an ally, training managers. And again, as a workplace behavioral health researcher and educator, it really makes me very happy to see the investment in mental health and well-being. Depression is one of the major risk factors for suicide. However, most people who struggle with depression do not attempt suicide. I think that is really important for us to remember. But when we're able to address depression, we are reducing many of the same risk factors that increase risk for suicide. And I think over the past 10 years, I've seen workplaces really act to reduce depression, but sometimes they forget to mention suicide. They probably don't forget, they're uncomfortable. getting to the related factor of suicide. And so by focusing on suicide prevention, we're automatically addressing mental health and well-being in a broader sense. But when we focus only on depression and anxiety, we often leave out suicide.
Thank you. And the last question is, how do we help people at work feel psychologically safe to seek help when it's needed, especially if they worry about, negative job consequences, judgment by colleagues, etc.?
That's a really important question, and there's a lot of research that's coming up now about psychological safety. I think the upstream approaches are part of that magic sauce of how do we improve psychological safety. Because what I found in doing this work for 20 plus years is when you have a champion in the workplace, when you have allies that are willing to share their story about getting help, about recovery, about resilience, that changes the culture so much more than any training or fancy brochure or app. We can have all different types of midstream and downstream approaches, but if no one is comfortable using them, they're not going to make a difference in terms of reducing suicide rates at work. So I really feel like the upstream approach, and it takes longer, and it's a harder investment really, because it's not check the box. But when we can cultivate leaders that talk about their experience, that encourage help seeking in all different aspects of work, we make it be a culture where it's okay if I'm not okay. And I know that if I'm open and honest about that, my workplace cares about me. They want me to be here. They want me to be productive. And they also want me to be psychologically well, because they know that affects their bottom line too. So the more that we can have the messages throughout the workplace and really bake that into all aspects and integrate it, I think that's where we're going to have, the best ROI, if you will, for our investment in suicide prevention.
Great. Thank you, Dr. Frey. And thanks everyone for attending our webinar. Appreciate it.
All right. Thank you so much.